Good morning.
Good morning.
Oh, it's good to see you.
You too, Carolyn.
Thank you, Dr. Rosensweet. Happy to have you here. We are going to close all competing interests like cats and crazy things like that. Many nice questions came in, and as always, thank you so much for taking your time to answer them.
My
Shall
pleasure.
we start? A little bit of, anyway, we'll work it out. Let me go ahead and just start. So, welcome to the women. Welcome to everyone. Question number 1 is coming in. May we discuss the issue of sleep? The woman is saying, I was doing really well and getting 5 hours of sleep per night. I would wake up and then fall back to sleep for 2 to 3 hours. Now I'm waking every hour. I'm taking progesterone in the AM, also in the PM. I take the estrogen patch and also testosterone cream. I really don't know what to do to be able to get to sleep at night and sleep through the night. And I think that this happens for a lot of us, and none of us really know what to do about it. So we were hoping you could shed some light on that one.
Such a crucial issue. It's so common amongst women in the perimenopause and certainly women in the menopause to start getting a significant sleep disturbance, and we all know what that's like. All you gotta do is lose a night's sleep or 2 or 10, and life changes. And there are definitely hormonal reasons. I'm always curious when a woman says that she's having challenges with her sleep to ask her, how did you sleep 10 years ago? And by far, the most common thing that I hear is, oh, I was a great sleeper. How'd you sleep in your 20s? Oh, no problem. And you can pretty much, when a woman says that, and again, that's the most common thing she's going to say. It's not universal. There are some women who have lifetime sleep issues, and those are a little more challenging. But let's take the most common thing where a woman did sleep very well in her 20s. And then you can pretty much track the hormonal changes. And when you ask her, when did you start having any kind of sleep challenges? And she'll say, I'll give you an example. She'll say, well, my mid-30s, actually. I slept well until then. And I would then ask, were you having regular periods in your mid-30s? Yes, I was. Here's what we just learned. And I explain this in the book, Happy, Healthy Hormones, that it's possible for progesterone to decline deeper and earlier than estrogen declines. As I've said many times, all women have their peak hormonal output from their ovaries, plus or minus 2 years around the age 20. That's when they are the absolute highest.
Right.
And then all ovarian hormones start to decline. And a common situation is the progesterone declines earlier and deeper than the estrogen. Even though she's still ovulating, and in order to produce any progesterone of significance, a woman must ovulate. If she has a cycle where she does not ovulate, she does not produce any progesterone of significance.
Right.
And so when a woman says, yeah, I slept well in my 20s, started getting sleep issues when I was in my 30s, I still had very regular periods. We know the situation is her progesterone has, like her estrogen and her testosterone, has been declining, but the progesterone was declining earlier and deeper than the estrogen. Well,
Got it.
progesterone really relates to sleep in this way. It is the great calmer. For example, if I were to inject the proper dose of progesterone intravenous into anyone, male or female, we could be put to sleep so deep that surgery could be performed on us. That's a very unusual biochemical right there, especially in the world of hormones. Most of the hormones that you can name are animators.
Yeah.
Adrenaline, cortisol, estrogen, animator, testosterone, animator. These are recruited for the fight or flight stuff.
Right.
That you encounter, not progesterone. Progesterone is the great calmer. And
sorry, go ahead.
And when you start losing your progesterone, you're not as calm, you don't sleep as well. So that can be, in the perimenopause, the very first thing I'm thinking of. And we love women to pick up on these hormonal issues in the perimenopause because they can be addressed even with over-the-counter progesterone. It's not my favorite way to do it. Those are in creams. I much prefer our organic oils. But a woman can address that earlier decline in her 30s with progesterone. Be on the lookout for it. Another way that will show up, or can show up, that doesn't even relate to sleep, is estrogen and progesterone are in this exquisite balance. And if the estrogen's declining deeper and faster, if the progesterone is declining deeper and faster than the progesterone, even though the estrogen's lower, the progesterone's lower still, that balance is not there. And you start getting a prevalence and a predominance of the estrogen stimulating symptoms. Since estrogen stimulates breast glandular tissue, if you don't have the progesterone balance, a woman in her mid-30s can start getting breast tenderness. Or you could get the stimulatory effects not balanced by progesterone on the uterus, which means you can start getting PMS and uterine cramps when you haven't had them for a decade. These are the signals that the progesterone is declining deeper and faster than the estrogen.
Okay, so 2 words stick out for me right there. Signaling, actually 3, signaling, education, and then balance. Balance is so important. So she is saying that she does take progesterone in the morning and she's also taking it in the evening. I mean,
I'd like to continue with the total overview.
Okay.
That's a good thing to raise because there are occasions in which we recommend that a woman take progesterone during the day. But hey, listen, we're talking about sleep.
Right.
And sleep issues prevail, and they're of the highest priority. So when we recommend that women take, and we prescribe progesterone for women, we always say, take your progesterone at night. Take all your progesterone at night. For biest or the estrogens, we want the women to take them twice a day. Not for progesterone. We say, take all your progesterone at night, for the very reason that can really restore woman's ability to sleep. Just taking the progesterone at night. Now, yes, there are instances where we also recommend that progesterone be taken during the day, and especially when women have some daytime anxiety that they didn't used to have. Ooh. And there's only a caveat with taking progesterone during the day, and that is don't take so much that you get groggy.
Right.
Otherwise, you cannot operate heavy machinery, including your construction cranes or flying airplanes or driving cars.
Yes, I was flying my airplane yesterday, and I did not take my progesterone.
That was very good. You're flying your private jet? Is that what you're?
No, I'm doing 747s these days.
You're flying 747.
Of course, the best.
Well, I'm so glad you didn't take your progesterone while you were flying. And it's still a matter of dosage. I mean, a woman who's got daytime anxiety and actually benefits from progesterone all you do is you just take the right amount, and you don't take too much. And if you take too much, you're going to get groggy or wonky. And so
Yeah.
you just back the dosage down.
Got it.
When that's a less common situation, we're more commonly, close to universally dealing with sleep disturbance in women. And so we are suggesting to most women, you take your progesterone at night. And not only that, we'll gradually increase that progesterone dose. And if we can't get sufficient amount of progesterone in through the organic oils, through the skin, because there's a limit to how concentrated we can make that, we'll start using oral progesterone, which is safe. Not oral estrogen, not oral testosterone. Oral estrogen has definitely got some issues with it. So we don't use oral estrogen ever. In any form, oral, isn't ever. Of course, there was one exception in my life, and that was me treating my mother who couldn't deal with the creams. But and we don't do testosterone orally, but we can take progesterone, we can take DHEA orally, and there's no problem there. And why would we want to switch to oral? We're able to get the dosages higher. And we start low with progesterone, we always start with the topical. I always start with applying it to the skin. And we keep on cranking up those dosages to see if a woman who is having sleep disturbance can benefit from the progesterone. And we'll crank that dose up quite high. And although it's, even if we go to oral, and we'll do that also, we'll go to oral progesterone. And oral progesterone has a special sleep advantage because of one of its metabolites. I'm not going to go into the weeds and name that metabolite, but there is a reason to switch to oral when sleep's an issue. And what we always do is I always supply women with 2 different bottles of progesterone capsules compounded from compounding pharmacies. I supply them with a bottle of 30 capsules of 50 milligrams and 30 capsules of 25 milligrams. And we have them start at 50 milligrams a night. And if the first night or 2 they're not sleeping well, we go up to 75. And if in a couple nights they're not sleeping well, we'll go up to 100. And we'll keep increasing that. And the most common dosage that benefits women's sleep in my practice is 75 milligrams. These are where women are most happy. But you know what? It's a range thing. And there's women who are on 100, there's women on 125, 150, and less common, in fact, far less common, we'll go up to 175, 200, even up to 225. If that will benefit a woman's sleep, those dosages of progesterone, all the more power to us. And it'll do a lot of other good things as well. So I have no hesitation to go up to 225, and I'd even go higher if necessary. And just as a comparison, these are not extraordinary dosages. Several years ago, pharmaceutical manufacturers got onto the oral progesterone bandwagon. And they use a bioidentical progesterone, same molecule as the ovary produces. However, they put them in these capsules with peanut oil and these dyes and some other stuff, and I don't get it. I mean, why in the world would you? How are they getting away with peanut oil? It really surprises me. There's so much peanut allergy out there.
Yeah.
But what they chose to produce is 2 dosage sizes, 100 milligrams and 200 milligrams. So just to give you a comparison. And I much prefer to get it finely titrated, finely tuned, and I gave you the ritual for that.
Yeah.
Now, let me give you a little more information in case you haven't had enough.
Never can get enough.
I gave you one example of a 35-year-old who was still regularly menstruating, which means she was still getting substantial progesterone, but she may be in that earlier and deeper progesterone decline situation. Let's go to the second scenario. This is a 40-year-old woman. Her periods have gotten irregular. She was clockwork regular for decades, and now she's getting irregular periods. And in the old days, she was getting her period clockwork every 28 days. And now she's having cycles where she still has an occasional 28-day on the button cycle, but then she's getting some 30s, some 35s, some 25 days cycles. And here's what's going on with that woman. On those months when they're not clockwork 28 like they used to be, those off months, she's not ovulating. That's a major progesterone occurrence worth noting, because if she's not ovulating, she's hardly producing any progesterone, just the progesterone that's coming out of her adrenal gland, which is minuscule compared to what comes out of the ovary. If this woman doesn't have sleep disturbance, I'll eat my hat. So I don't have a hat, actually, that I wear, but
well, you ate it.
Oh, yeah, I ate my hat. Thank you.
That makes sense.
So that scenario, when a woman's having irregular periods, she is not producing hardly any progesterone, and she's bound to have sleep and mood issues, because progesterone is the great calmer and the great sleeper. When it comes time for that, it's time to seek a licensed healthcare provider that's specializing in treating women in menopause. It's time to get robust doses of progesterone, whatever it will take. And this woman is going to be helped by progesterone.
Right.
Now, this also pertains to any woman who's not having periods any longer. Her ovaries no longer producing progesterone at all, and she's in the same situation of the woman who's not ovulating. You got to be a little careful with the woman who's intermittently ovulating, and that's not common. That's not uncommon. When a woman's having an occasional or even frequent regular cycle, and then she goes into an irregular cycle. When she has the regular cycle, when she has the 28-day cycle, she is producing progesterone. Maybe not as much as she did in her 20s, but she's still producing a robust amount of progesterone. And what do you do in that situation? Because you can't predict whether it's going to be a regular cycle that she's in beforehand. You can't tell. Right. You can really tell if she's implemented and she's on an irregular cycle. She was happy with 125 milligrams. Let me give you a rather robust example of oral progesterone when she goes to sleep. If she does that on a time when she actually ovulated, she's going to get groggy. She's not going to like it. She'll wake up groggy. She'll be on an overdose of progesterone, because if she's in a cycle in which she ovulated, she's going to already have a sufficient amount of progesterone, and that 125 milligrams is going to feel like too much. Now, some women, of course, can tell when they ovulate. And if a woman can tell when she ovulates, that wouldn't be a cycle necessarily that you would augment or replenish rich levels of progesterone. But still, if she still has been irregular, she still may want some progesterone, because it could be that situation where she had early progesterone decline deeper than the estrogen. So you can in that case, you can use transdermal topical progesterone in those cycles. So here we're talking about the perimenopause or early menopause.
Nice.
Now, progesterone is far from the only ovarian hormone that relates to sleep. Oh my God. Estrogen relates to sleep big time. I mean, big time. So when you get declining estrogen, sleep issues are very common. There are different type of sleep issues. There's a type of thing where the woman fell asleep quite well, and then she woke up at 2 a.m. with a night sweat, drenched her nightgown. Or she didn't wake up with a night sweat, but she woke up and she had a warm rush or a hot flash. That's just a lesser degree of what happens during a night sweat. Or she just woke up and she can't get back to sleep. And this is a very common situation. She's got a racing mind. She's thinking. Well, that is an estrogen deficiency issue, because the body does not like low estrogen. It's stressed by low estrogen. That stress can go so far as to produce a hot flash or a warm rush, And more important than that, it can trigger the biology of the stress response. So that woman who woke up with racing mind, she had some equivalent of a minor hot flash, a signal to her brain that the estrogen was too low, and she did the biology of the stress response right there in the middle of the night, 2 a.m. And what she did is at the vanguard of that stress response, many biochemicals are recruited to fight or flee from the saber-toothed tiger. The main ones are adrenaline and cortisol. Estrogen's also recruited, but there's not as much around. Testosterone's recruited, absolutely. But it's the adrenaline.
Ugh.
Because adrenaline is an animator of the highest order. As many college students and medical students know, because 4 times a year I would take an artificial adrenaline by mouth to be able to pull all-nighters to study prior to midterms and finals. And my God, that stuff worked. I would pop that capsule and my mind would be just so animated and able to stay up all night, no problem. And even go into the next morning and take the test, no problem. But oh my God, the crash that took place after that.
Don't I know? We took them for fun as kids. I mean, we didn't know. We were 13. We thought that was great. Solve the problems of the world.
So this is what's happening. A woman is getting some adrenaline squirted out from her adrenal glands in the middle of the night because she was stressed by the low estrogen and the warm rush or hot flash phenomena that she may or may not have felt. Well, when a woman in midlife squirts out some adrenaline, the issue then becomes, how long does it take for her body to dismantle that adrenaline? Because she's not going back to sleep until her body has dismantled or metabolized that adrenaline and excreted it. And midlife livers are not in the same shape that 20-year-old livers are. Like, for example, as I've used many times, when I was in medical school, I would drink a cup of coffee at 10 o'clock. And then in the evening, and then I would drink a cup of coffee at 11 o'clock. I'd have to drink a cup of coffee every hour to stay awake because my 20-some-year-old liver was so efficient that I would drink the caffeine and it would get rid of it within about an hour. So I'd have to drink a cup of coffee an hour to stay awake. Well, I wouldn't dream of taking a cup of coffee at dinner now because my other non-20-year-old liver will not process that caffeine like it did, and I'll stay awake.
Right.
The same thing happens with adrenaline. A woman wakes up in the middle of the night and she's got some adrenaline squirting around there, and she's at the mercy of how efficient her midlife liver is. And midlife livers very rarely have the same abilities that young livers do. So there's the second aspect of sleep disturbance related to hormones that relates to insufficient estrogen. And we are constantly, especially in the menopausal women, addressing both things expertly, replenishing progesterone at the proper level and estrogen at the proper level. And we go through great lengths and we describe that in the book on how to determine these dosages for women.
And let me just say always, because I love to say it, pages 326 and 327 are going to really get you through, the beginning parts of that to try to find what your right dosages might be.
And that's the art, is getting these dosages correct. And, the restoration and replenishing of proper amounts of progesterone and estrogen in the form of Bhrt are going to handle a lot of these sleep issues. And we're keeping our focus on that sleep issues because that's one of our major intentions. How much progesterone do we need? How much Bhrt do we need to restore decent sleep? Now, there are other moving parts in sleep, and they're not as predominant in a menopausal woman as the estrogen deficiency and the progesterone deficiency, but they can definitely play. And there's issues of hypoglycemia that sometimes need to be addressed. And you can wake up with hypoglycemia in the middle of the night, and this can be sorted out by your functional medicine provider. And yeah, there's melatonin can be supplemented to good advantage. And beyond that, we're going beyond the technicalities of what relate to common menopause. So I'm going to halt it there. One thing for that woman who asked the question is you need to go through the whole ritual and read the book, Ins and Outs. I'm sorry, Happy Healthy Hormones. It's on Ins and Outs of Menopause.
Yes, you can download it free. It's great. It's good.
And you'll get an idea of what the proper way to address menopause is. But I would take that morning dose of progesterone just for a quick start, and don't take it in the morning. Just take double the dose of progesterone in the evening. You know, when you take too much progesterone in the evening, progesterone is so calming that you're going to wake up in the morning feeling groggy, as if you had taken a sleeping pill. That dosage is too much. But if you haven't, I mean, we often have women keep on increasing that nocturnal progesterone dose until they wake up groggy. That would mean too much, and then we have them back down in the dosages.
Right.
One thing that, you could try, and I just don't know what dosages the questioner is taking, is don't take that progesterone in the morning. Add it to your evening progesterone and see if that doesn't make a difference. But you can tell from the amount of diving into the depth of this issue that I've done that there's more to getting this right.
A lot of moving parts. Hip bones knee bones connected to the hip bones, connected to the every other bone. It's complex, and I really appreciate the way that you put it out there to us, to where it makes sense, because menopause is really complex, and yeah.
And it does come down to this: the job is always the same. Is from any woman who's suspecting hormonal issues and sleep disturbances, you really want to suspect hormones big time.
In a big way.
Your job is to find a healthcare provider that is specializing in treating women in menopause, because you're going to need their technical assistance. Yes, you learning some things can make you a better partner in the process, and it's more enjoyable for most women. In fact, that's why I originally wrote the book, so that you could be a very active partner in the dose determining process. But at the same time, bottom line, your job with sleep disturbance is to find someone who's excellent, because there's so much more at stake than sleep. There's bones, there's muscles, there's libido, there's vagina. There's never having to use canes, walkers, wheelchairs, adult diapers. There's clarity of thinking. There's so many things else at else at stake. Sleep disturbance is just a warning that something very significant is happening, and I can't emphasize it enough. Your job then becomes find, no matter how much shopping you have to do, someone who's really expert at treating women in menopause. And I would check in with the menopause method. That's what we ourselves, we train nurse practitioners and physicians to be specialists in treating women in menopause with bioidentical hormones. But that's the important thing. You start getting sleep disturbance, yes, you can address it with over-the-counter progesterone, or even, but this is the day, I can't think of anything better for you, that you go out and go shopping. This is your job. Find someone who's really great at this, who really loves this stuff, who's got the education and experience and mentoring to do a fabulous job here with you. And then it's lifelong, because it isn't just the sleep. It's all those other things that matter so much.
Right, and that gets into a whole other thing. And I've got these other questions here. I want to welcome all of our ladies. You know, my cursor doesn't work, so it goes up and down. But I see Susan and Liza and Melanie and Kara and our other Facebook users. I see your questions. I will get them screenshotted to me, and we will be able to get to them. Absolutely. I gotta ask this one really quickly. I don't know if there's ever a quickly. I always say that, and I gotta stop it. Is it okay to take BHRT if you smoke?
Well, I was a smoker. I was a smoker in medical school. 2/3 of my medical school class in the mid-60s were smokers. And you know, you got me in a soft spot here because I've paid the price for smoking that I can feel to this very day. And I know I have friends who are smokers, and you know, you've heard it a million times. You're probably really upset every time someone suggests that you stop smoking. But I have to pause and say, smoking is not safe. And it's not like it's possibly not safe. It isn't safe. And one of the things that are vulnerable when you're smoking is the arteries. And for example, it really matters what kind of hormones you take, because if your arteries are vulnerable to get arterial sclerosis from the smoking, then they're vulnerable to clot. Because that's the problem with the arterial sclerosis. Yet, it slowly closes off the arteries, but it does it very slowly, and that's not the problem. It's the clots that can form. So one thing for sure is, if you're smoking and you can take hormones, yes, you can, and many women have. Many smokers have taken hormones, but you surely don't want to take any oral estrogens, which can promote coagulation. Well, no one should be taking oral estrogens anyway.
Yeah.
So you want to get topical estrogens, those that you apply to your skin or mucous membranes. But
I'm sorry that I threw that at you.
Sorry that this came up, actually, because it's a tender topic.
It is a tender topic.
Really, so I'm going to go into it. Because having smoked in my early life, I quit 50 times. I wouldn't doubt that this person who asked this question has
anybody who's smoked, yeah, of course.
And then the real issue becomes, why am I smoking? Because there's reasons why people smoke and drink excessive amounts of alcohol, just to throw that one in too, or take marijuana or any other drugs. It's a mood issue. All of these things, and overeat and eat sweets, these are all mood alterers, which means we smoke, we drink, we take these substances because we're not accepting the mood that we're in. And what I'm talking about is, instead of having a good mood, we slip into a non-good mood and we want to medicate. So we use simple carbohydrates, sweets, tobacco, nicotine, alcohol, drugs, etc., to mood alter. So the question is there anything more effective in addressing a lowered mood? And there is. There is emotional tools, there's bodies of knowledge that can help you identify when you slipped into a low mood. And there's good things that you can do for that don't injure your life, that don't injure your body. And that's a prime piece of good things to know. How do I not injure myself? You're going to want that. You're not going to want to suffer. None of us like to suffer. We want to keep improving our lives. So what works for healing any addiction is to get the information, tools, and support that help you address the uncomfortable emotions and thoughts that are at the cornerstone of a diminished mood. So we're talking anxiety, we're talking depression. Inside of any anxiety and depression, there's fear, there's emotions inside any anxiety and depression. Those are general 19th century words or 20th century words, anxiety and depression. What's going on there, you've got uncomfortable feelings rising up and you're partially suppressing them into these vague words like anxiety and depression. Inside of every anxiety and depression is fear or sadness or anger or shame or guilt or emptiness or loneliness.
Right. Happy, mad, sad, glad.
Or hopelessness. This is what's inside of there. And thus the medicine becomes, can you acquire information and skills to deal with these emotions effectively? And it will change your life. And I'm here to inspire you to go out and seek the information, tools, and support. There are counselors in your town. There are psychologists. There are social workers. There's information on the internet that can help you identify and heal in a very successful way by yourself, guiding yourself, any uncomfortable feeling you ever have. And so if there's popular requests on this particular website, I will go deeper into that, but I'm going to pause right now and encourage you to get at the reasons why you're smoking. Oh, that's a piece of work, but it's so rewarding. It's life-changing for you because these dips can be healed and you can become a happy person and not need any substances.
It's a very freeing experience.
It's very freeing.
Because
so let's return to menopause.
Yes, of course.
Version.
Yeah, of course. Okay. So this woman says, and I'm acknowledging everyone's questions here. I'm going to get to these first. I'm doing the best I can here. When a woman breastfeeds, does she lose all of her sex hormones?
Good questions. There are so many profound complexities around pregnancy, labor, delivery, childbirth, nursing. It's one of the most life-changing things that can occur to a human being, and that's women and men. And most women, they restore to their normal hormone production, and some women don't. And for example, breastfeeding can quiet that ovary down and prevent ovulation. But still, the woman should be producing adequate levels of estrogen. And yes, hormonal imbalances can occur in the postnatal state and during breastfeeding. But there's no reason that she has to lose all of her testosterone, for example. She may not ovulate, this may not have sufficient progesterone. But when there is, and the question was around, does she lose all of her hormones? No, she does not. And when there's an issue, she can be tested. When she, if she's going to breastfeed, she may not get her period back. And that's a hormonal issue right there.
Mm-hmm.
And then, it's very natural for other reasons to turn one's attention towards the baby and breastfeeding.
Yes.
And in a marriage that's got a lot of understanding and a lot of space, the level of love that can occur in that marriage with a new child can amplify manyfold for those men and those women who take the time and care to realize that now their marriage is amplified manyfold by the birth of a child. And boy, if there ever was a time that the divine has opened up a window for deepening of love and deepening of intimacy, that is the time. And it requires some conscious attention, because it's super easy for a mother to shift all of her attention to the baby, especially when there's been marital challenges, and especially if the husband is starting to place demands, including for intimacy. So it's a field where two things can happen, two directions can take place. One is the woman is not addressed with sensitivity and trust and caring and openness and love by the husband, and it's a real chain reaction for challenges. And the other is the man can be understanding, bask in the ocean of new love that's available to the husband, that's indescribable except to those fathers who have been present and have opened to that love. And the inspiration and the beauty of young motherhood can, a man is now privy to beauty that is just unparalleled. And it's some of the highest beauty, not the only beauty, that a man can experience if he's awake and aware and sensitive and spacious. So this is the challenge of men. And boy, I'm venturing into some more deep territory there. Women do have their challenge. It's too easy in some instances to retreat emotionally to the baby and motherhood and not realize that the thing that's going to serve this baby is the health of that marriage. So make choices that enhance the health of the marriage. Now, I'm walking into a field that there are many experts in, so I'm not going to go further into it because it's way beyond better living through biochemistry and hormones. And what in the heck makes hormones function normally in a woman, for example? Well,
Right.
It can be based on things that truly matter to you.
Yes.
And so the hormones can be thrown off if the emotions in the mind get thrown off, and if old pains get. So we're now way over my pay grade. But what comes first, the chicken or the egg? Hormonal imbalances, or not being able to rise to the occasion of the love that's possible and the intimacy that's possible. So the perinatal period, I'm going to include pregnancy, labor, delivery, the first months of a baby's life, breastfeeding. Oh my God, this is a universe.
Talk about
those of you who master it, and it's quite natural to master it, and everything, great things can happen here as never before. You can be privy to depths of love and intimacy and connection that only those who have experienced this can really. Words don't do it. Or you can get into emotional and life challenges and relational challenges that can disrupt everything, including your hormones. So it's a much, much deeper topic, and I'm going to turn the key on anything I have. But I delivered babies at home for many, many years, 400 of them. And I've been privy to pregnancy, labors, and deliveries, including my one and only. And I've seen women and men triumph, and that's not so common. They get to enter a universe of love and intimacy and solidity of that relationship that the family is based upon. It's so gorgeous, it's unreal, and it's so sacred. Or they get to break down, and or they can do a combination. So, boy, do I wish there was training for this one. I wish I had the training when I was young to deal with the many issues that can be provoked during these highly life-accelerated situations. And oops, I thought I was going to turn the key. I'm going to turn it now.
It's a question that I've been wanting to ask you that question, a particular question. We can get into that and go, as you say, deep into the weeds in regards to that and how it affects hormones and so on and so forth. And so I'll just go ahead and move on.
Thank you, Gail.
No, not a problem. This question comes in stating, I was overdosed on pellets, and I believe that this gave me LVDD, which is left ventricular diastolic dysfunction. I'm wondering if taking hormones via a different route will be okay for me to do.
Yes. Cardiac dysfunction and cardiac issues, and they do occur. And the thing that I'm going to place stock in is that you had left ventricular diastolic disorder diagnosed by a cardiologist. And the thing I'm unsure about is, was it the pellets that did this? I'm not knowledge enough or experienced enough with pellets, because I'm a non-advocate of pellets, period. I do not recommend pellets at all. And I've been in the process of converting many women from pellets into the topicals. There's many reasons why I don't do that. And I know that there are advocates of pellets out there. And I know that there's many women who have gotten quite high, and men as well, from pellets. But I'm going to take a stand and say I do not advocate the use of pellets to address hormonal issues. But I'm not going to say that the pellets cause the left ventricular diastolic disorder, because I'm not knowledgeable enough with that particular diagnosis. But I would like to take the opportunity that if you're getting low in hormones and you're getting hormonal insufficiency symptoms and you're in menopause, obviously you must have been if you took pellets, that's an important thing to address as well.
Yes.
It's important for cardiac health. And now here it goes. It's the same story 100% of the time. You want to be in the hands of an expert. You want to be exploring a hormonal program with someone who's specializing in this. They've made it their life's professional work to specialize in hormones. And there isn't a single issue that a woman has going into menopause that, with great microscopic care and due diligence, you can't sort out.
Right.
For example,
so hopeful.
For example, a rather common issue is a young woman was on the birth control pill and had thrombophlebitis and maybe even a pulmonary embolus from taking oral estrogens. Well, we're dealing with this all the time. I'm taking a medical history off of our exquisite questionnaire, and I'm seeing that she was on the birth control pills, and she did have a clot, and she even had a pulmonary embolus. I had a woman that we're working with now, that she had thrombophlebitis. That means a clot in her leg vein that broke loose and traveled up to her heart. And because she had a hole in her heart, a congenital hole in her heart called a patent foramen ovale between the atrium, that clot traveled right on through and up to her brain. Ordinarily, that thing would be stopped by the lungs, but it went through the heart. She had a stroke. So we are dealing with coagulation issues in some women. Well, what do? We do an exquisite, thorough coagulation evaluation. And we do that before hormones, and then we repeat it when on hormones. And there is a very sophisticated coagulation laboratory testing that was born in Arizona in a lab called Chemex. And LabCorp thought so much of it that they purchased. Well, there was an intervening purchase by Esoterics, then LabCorp purchased Esoterics. These tests, or you can go get these tests just by going into your local LabCorp, for example, does it for sure. And I wouldn't doubt that the other big laboratories do these sophisticated coagulation profiles. And we get to see if a woman has, instead of balanced coagulation, that means she doesn't bleed too much and she doesn't clot too easily. She's balanced. We can assess that. And when we find a woman has a propensity to coagulate prior to giving her hormones, we give her nutritional supplements, which for the most part can restore someone to that beautiful balance. Sometimes even if you have to take a baby aspirin, or you have to do some of the more sophisticated anticoagulants, you do what you need to do to restore that balance so a woman's doesn't have a propensity to hypercoagulate.
Right.
And you know, it's so easy. I mean, you take enough vitamin C and enough omega-3 fats and enough vitamin E, and most patients, I can get them to bruise, which means they're excessively, they're bleeding too easily. And then we just back them down to where they're not bruising. We can affect the coagulation and we can affect the testing. And that's very important. Now, because we are strong advocates of almost never using oral estrogen, I mean, 0.0001% of women actually need oral estrogens, and it's just for compliance reasons in the elderly. Don't use oral estrogen, because what got women in birth control pills hypercoagulable was the oral estrogen. Topical estrogen does not do this. But you never say never. There are some women that even on topical hormones start getting aches in their legs, like when they had that thrombophlebitis. Now, I'm using thrombophlebitis as an example because it's something I know. But medically, when we get a hint that there's something going on in the cardiovascular system, we evaluate. We pause and we evaluate. So I gave you the example of evaluating a coagulation issue, because they're very common. Left ventricular diastolic disorder, in my experience, is not that common. But when I say we, I don't mean me. I evaluate the hormones and I refer to a cardiologist, because this is their bread and butter. And a cardiologist can monitor you. They can do exquisite tests to evaluate that left ventricular disorder. And the plot I would suggest, although I don't want to say so for this particular patient because I don't know this patient, but in general, what I would do is, if lack of hormones was debilitating a woman's life, and she wasn't even very symptomatic from left ventricular diastolic disorder, I would implement the hormones and work hand in glove with a cardiologist to evaluate how she's responding to the hormones. And I certainly would include testosterone, which is very important for the heart muscle. Left ventricular disorder, if I am correct about this, please don't quote me on this. Cardiologists are the ones we need to refer to. But that can eventually lead to congestive heart failure, because they're not getting enough proper heart pump of the blood, and it's backing up into the lungs. And there's a Danish study that shows that testosterone can really help a heart that doesn't have enough muscular strength. But I don't know that this is this particular questionnaires issue at all. But what I am pointing out is this: cardiologists have exquisite tools and instruments to keep really great track of these issues, like almost any issue you can name. So what I would do if I was the provider for this woman is I would want to consult with her cardiologist and see if we can together plot out a monitoring path in which hormones could be implemented and the cardiologist could evaluate. And because I don't know the specifics of left ventricular disorder, I cannot advise that this hormones can be taken. I don't know. I don't know enough about it. I've never encountered it. But what could be done is you could find an expert menopause, someone who's expert in treating women in menopause with bioidentical hormones, and you could find the cardiologist and the two of you could consult. The cardiologist and the expert in menopause could consult. Is, can a program be mapped out for you that you can be evaluated along the way and see what excellent hormone replenishment can do and see what its effect is? Again, because I don't know LVDD, but particularly, I don't know enough to advise you personally, but your cardiologist or a cardiologist, sometimes traditional cardiologists are not willing to go outside and really microscope down on some of these more challenging issues. But there are cardiologists who do. And so your job might be finding a menopause specialist and a cardiologist that are willing to work together and plot out a pathway to replenishing hormones and monitoring that heart very carefully. Because I believe, I don't know because I've never dealt with LVDD, that a plan could be done, and it's worth it. Because we're talking about your whole life here. And I assert that there's a decent possibility. I can't say 100% because I've never gotten involved in a case like this. But there's a decent possibility that you could get that process right. And once you got it right, it'd be a piece of cake for the rest of your life.
Smooth sailing.
Smooth sailing from then on. Okay, you got to put due diligence, the time, the energy, and possibly money right now. But it is so worth it, including for the health of your heart. And
you bet.
Needed for the health of your heart. So, sorry, I can't get more specific on your case because I just can't, because I'm not experienced with LVDD. But I can give you the roadmap, which is get an expert in menopause and get an expert cardiologist who's willing to consult with and map out a program of you start the hormones and the cardiologist is evaluating you. And boy, do they have the instruments to do it. I love those instruments. There's so many tools that cardiologists have to evaluate the heart.
Yeah, I saw a cardiologist prior to taking hormones, and I fell in love with her. She's just an amazing woman, and I got the green light. I was so happy, but I was really happy that I didn't know, that was something that I should do, and it was just another little tool in my toolbox that I would learn, and gratefully so. We're going to close out because we're at that bewitching hour, but I do want to ask you this. It's a yes or no answer, and I know how passionate you are about this, and it came up right here on what you will screenshot me. Thank you, thank you, thank you. The woman asks, should I stay on hormones the rest of my life or not?
Yes.
Okay. Had a feeling that might be a big
I didn't think you could ask me a yes or no question and I'd actually be able to deliver a yes or no.
I know how you feel about that, and I know.
Yes, the answer is yes. There's I can't even think of an exception.
Ever. Yes, I get that. Well, me.
Whole life. Right into the day we leave Earth. Here's mine, and I will be taking these every day that I've got the blessing of staying on Earth.
I know, for all of us.
Would you tell them what's taking place on?
I have put this out there, and it is on the Ins and Outs of Menopause group with David Rosensweet, MD, who's sitting in front of us. He is going to be in the interviewer's seat on Thursday with a really, really interesting gentleman who is a pharmacist, Dr. Jim Herntzer. And Dr. Rosensweet is going to be interviewing him. He is a member of our group. He chimes in every once in a while. And this is an interview I am really looking forward to. I appreciate that you're doing it. And I know, like this is a yes, just a yes, that everybody's really going to enjoy this interview. It'll be Thursday, this coming Thursday, normal time, 7 a.m. PST, 10 a.m. Eastern Standard Time. So be there. You just got to be there.
And Jim is a pharmacist. He's not actually a doctor, but he is a pharmacist. And he has been prescribing because he can do that. And he's been prescribing for decades through consulting with doctors who actually write the prescriptions. But Jim's a wonderful man and a pioneer in this whole field of bioidenticals. Oh my God.
Yes, and he is a friend of mine on Facebook, believe it or not. And as I said, he does chime in from time to time, and I think it's going to be a great interview. You're the interviewer, he's the interviewee, and you guys will make it happen, and we are going to learn a lot from that interview. I know it. I mean, I just already know it. So
And then you and I are back on next Tuesday and Thursday.
we are indeed. And oh, I have my work cut out for me. Thank you very much. These are some amazing questions that came up this morning, like crazy amazing.
All right. Well, I'm going to sign off, Carolyn. And until next time, everybody.
Indeed. So we'll see you on Thursday, ladies. Thank you, everybody, for coming up. Thank you, Dr. R, for screenshotting these to me. And yeah, have a great weekend. We'll talk soon, and everybody enjoy.